Good morning, everyone. Today we are going to see a case of central neurocytoma. 22-year-old lady with 32 weeks pregnancy presented with pregnancy-induced hypertension and intraventricular bleeding. Now, this lady was first delivered in the hospital and then taken for clot evacuation. Her MRI revealed a large, well-defined lobulated intraventricular mass in the left lateral ventricle with involvement of the intraventricular septum, and areas of hemorrhages were also noted. She was operated and the blood clot was. We received the blood clot for intraoperative diagnosis, that is frozen study and histopathology. But the frozen study and the squash smears were inconclusive. So we thought better not to exhaust this precious tissue for the frozen, and we took it for histopathology as it came inconclusive. So now histopathology revealed clusters of round to oval cells embedded in this blood clot. The cells have monomorphic round nuclei with finely speckled or the saltpeter-like chromatin and moderate amount of clear cytoplasm. Now, this clearing of cytoplasm feature is shared with oligodendrogliomas. The nuclear atypia, mitotic activity, necrosis was absent, and even calcification was absent. We did immunohistochemistry on this tissue, and synaptophysin was strongly expressed by these clear cells. Now, the central neurocytomas, they are also TTF1, L1 CAM, and NEWN positive. Now, NEWN positivity is also noted in the pineal parenchymal tumor of intermediate differentiation. However, the imaging, in such cases, imaging helps us to differentiate central neurocytoma from a pineal tumor. GFAP and OLIC2 was negative, so the possibility of oligodendroglioma was ruled out. EMA paranuclear dot positivity was absent, so ependymoma was ruled out, and the proliferation index was less than 1%. So we rendered a diagnosis of central neurocytoma, CNS WHO grade 2. Now the take home message in this case is a blood clot should always be sent for histological evaluation when you are suspecting any lesion. So this is the post-op scan. You can see the stent and the residual tumor. Central neurocytoma was first recognized as a distinct ventricular tumor by Hasson et al. With the features of benign clinical behavior and neuronal differentiation in the year 1982. These represent less than 1% of all the primary brain tumors. Now, in this category comes central neurocytoma, which is located in the ventricles, that is the lateral ventricle and the third ventricle. The extraventricular neurocytoma, which are located in the cerebral hemispheres, and the cerebellar liponeurocytoma, as the name suggests, are located in the cerebellar hemispheres. The central neurocytoma, the age group is young adults, that is between 20 to 40 years of age. It is rarely found in the pediatric age group. The extraventricular neurocytomas, these are most common in the fourth decade, and the cerebellar liponeurocytomas are very rare tumors. The central neurocytomas, as I said previously, are typically located in the lateral and the third ventricles. On imaging, they appear as solid cystic masses with calcification. Now, this calcification is nicely noted on CT scan. These are T1 isointense, and on the T2, they exhibit the typical soap bubble appearance, and these tumors most of the time show hemorrhages as well. These are grayish friable masses with foci of calcification and hemorrhage. Histopathology reveals sheets of monomorphic cells which have round to oval nuclei with stippled chromatin or saltpeter-like appearance. And the cytoplasm is clear, or that is also called as a halo. The vasculature here, you can see it is there may be thin capillaries, some may show thick walled vasculature as well as arborizing vasculature, and pseudomatous calcification may be present. Other features are fibrillary areas mimicking neuropil or irregular rosettes mimicking pineocytoma or perivascular rosettes mimicking ependymoma may be present. The tumors which show areas of hemorrhages may show organizing hematoma on histopathology. Certain central neurocytomas which show aggressive features, that is increased mitosis, microvascular proliferation and necrosis, are called atypical or anaplastic neurocytomas. The differential diagnosis for the central neurocytomas are oligodendrogliomas, which are IDH mutant tumors and are GFAP and OLIC2 positive. The pineocytomas or the pineal parenchymal tumor of intermediate differentiation show new positivity and synaptophysin positivity. However, their location is very distinct. So imaging helps differentiating these two tumors, and the ependymomas typically show paranuclear dot positivity on EMA. Coming to prognosis, central neurocytomas and extraventricular neurocytomas, when undergo complete surgical excision, show good prognosis. The proliferation index, the Ki67 proliferation index, when is less than 3%, these tumors show better prognosis, and the tumors with more than 3% are, are known to show worse prognosis, and there is a likelihood of recurrence. Extraventricular neurocytomas are benign tumors with low recurrence rate, and the cerebellar liponeurocytomas have a favorable prognosis after complete surgical excision. However, recurrences are known to occur. The atypical neurocytomas, as I talked previously, are the tumors which show aggressive histological features such as increased mitotic activity, necrosis, and microvascular proliferation, in addition to a high Ki67 proliferation index, that is more than 2 to 3%. They have aggressive behavior, and these should be subjected for adjuvant therapy. Today we discussed central neurocytoma. I hope you all liked this case. If you have any query regarding this, please mention it in the comment box. If you have query regarding, or if you want me to discuss any other specific tumor, please let me know regarding the same. And I hope you all are liking these cases. So please like, share and subscribe my channel. Thank you very much.